Greetings to everyone. I will be presenting my paper on study of various outcomes and complications after therapeutic penetrating keratoplasty in fungal corneal ulcers. Incidence of fungal keratitis is about 5 to 10% of total corneal infections, and in developed world it is about 6 to 35%, and in developing world it is 22 to more than 50%. Surgical treatment is required in approximately 1/3 cases of fungal keratitis due to failure of maximal antifungal treatment or perforation. Therapeutic penetrating keratoplasty is the surgical procedure of choice and are generally emergent or urgent procedure in which visual rehabilitation remains the secondary importance. To assess visual outcome and various complications after TPK in fungal keratitis patients is the main aim of this study. This was a hospital-based prospective interventional study conducted in upgraded Department of Ophthalmology at SVBB Hospital, LLRM Medical College. Total 20 patients with diagnosed fungal corneal ulcer fulfilling the inclusion-exclusion criteria underwent detailed ophthalmic examination and were treated surgically with TPK after obtaining an informed consent and were on regular follow-up till 6 months. Patients not responding to antifungal treatment for 4 weeks or with corneal perforation or with impending perforation following fungal corneal ulcer were included in our study. And patients with non-infective ulcers, corneal ulcers in previously grafted cornea, or corneal ulcer patients who refused for the study or not coming for follow-up, or with penetrating keratoplasty done for other indications, or fungal keratitis patients with endophthalmitis and patients having late abnormalities were excluded from our study. Moving on to results and observations, this is a table showing local predisposing factors distribution. We can see that vegetative trauma is the commonest risk factor for fungal keratitis. This is the direct microscopic examination of the corneal smears. 30% of our corneal smears were positive. And this is the fungal distribution of the same smears. Filamentous fungi were the commonest, that is 83.33%. And this is the result of culture and or reculture of the corneal specimens. We can see that 70% of the specimens were positive for culture. And fungal distribution was again filamentous fungi, that is Aspergillus was the commonest. And types of ulcer, non-healing ulcer were the commonest, that is 50%, followed by perforation or with impending perforation. We can see that fresh grafts that is preserved in MK media were associated with lesser number of complications, while glycerin preserved corneal grafts were associated with more number of complications. This is the pre-operative visual acuity. We can see that most of our patients in finger count close to phase 2 hand movement, and this is the table showing post-operative complications in corneal grafts. In our study, glaucoma, suture-related complications and vascularization were the commonest, that is 25% each, and other complications were also there. This is the table showing graft clarity at different follow-up times. We can see that at the end of 6 months, 3 patients were having 3+ graft clarity and 11 patients were having 2+ graft clarity. This is the table showing visual acuity at different follow-up times. Again, at the end of 6 months, most of the patients were having more than 1 meter finger count. And this is the table showing average post-op visual acuity over 6 months in different subset of patients. We can see that patients with non-healing ulcer without hypopyon were having a good visual acuity. And so outcome of therapeutic penetrating keratoplasty in fungal keratitis, we have 85% of the grafts were therapeutically successful, while 15% were failed graft. In our study, non-healing corneal ulcer, perforation and impending perforation in fungal keratitis were the main indication for TPK, and most common complications after TPK were found to be glaucoma, superficial and deep vascularization, and suture-related complications, which are seen in 25% of cases. Infection in the form of recurrence of host pathology was 10% in our study, and rate of graft failure or rejection was found to be 10%. Visual outcome after 6 months in majority of patients was between 3/60 to 1/60, followed by less than 1/60 to hand movement. Therefore, moderate grade visual acuity was seen. In our study, visual acuity was less and complications were more in patients having perforation or impending perforation in fungal keratitis. Better grade of corneal graft and lesser preservation time were favorable prognostic factors following TPK in fungal keratitis. In our study, MK media preserved corneal grafts showed better visual and functional outcome post TPK than glycerin preserved corneal grafts. Scleral or anterior chamber involvement, that is mainly hypopyon, were unfavorable, and proper patient compliance was also deemed important for the post-operative outcome. These are some images of our patients. These are the references. Thank you.
Thank you, Dr. Vaishali. Just a couple of quick comments. When you're preparing your thing, always do a spell check, because the word inclusion was wrongly spelled. in exclusion criteria and inclusion criteria. So if you go upwards, please change the spelling. Second is, there was a slide in which you mentioned vegetable trauma and then you mentioned trauma. What did you mean by trauma? Vegetable trauma is vegetable trauma, but trauma, possibly you meant mechanical trauma.
Any kind of mechanical
Yeah, so
trauma.
mention mechanical trauma to distinguish it from vegetable trauma, because you can't have a broad trauma word there because that encompasses all traumas. Yeah? And you mentioned in one of your penultimate slides, if scleral involvement had unfavorable outcome. You cannot give a conclusion when you've not mentioned it in the main body of your work. So in your main body, nowhere have you told us how many patients had scleral involvement and what was their outcome. You only talked about perforation, impending perforation, and regular non-healing ulcers. So you've not mentioned scleral. How can you conclude that scleral has an unfavorable outcome? On the basis of this 5-minute presentation, you cannot conclude. So never conclude anything which is not revealed to us as judges before the procedure. Yeah? Any other comments? Yeah.
I have a question. Doctor, Doctor?
She has a question.
Come.
What was
Please
your
come up.
post-op regimen? What was your treatment regimen? Your treatment regimen.
Ma'am, post-operatively, we give antifungals and steroids, that is prednisolone 1%, eye drops.
So from the day one, you start them on prednisolone also?
Yes,
Is it-
ma'am. Yes, ma'am. In high risk cases, like we start steroids from the day one.
It is not given on the first day. Usually we wait for 2 weeks to see the other treatment. So don't give the message that you start on the first day. Fungal keratitis is never given first day.
So that was what I wanted to know actually. Fine. Okay.
Also, you didn't tell us, did you do any smears, cultures of the corneas which you removed, the buttons which you removed?
No, sir. Post-operatively,
The
we send
buttons that you
specimen-
removed, did you know what kind of fungus was there? Aspergillus, yeast, candida, what was?
Sir, pre-operatively we did the smears and
And then
aspergillus
the
was-
buttons that you removed, you threw away?
No, sir, we send them for culture, but I didn't mention it.
Okay. But do you know what you found?
Yes, sir, aspergillus was again the
Predominant
fungus.
aspergillus.
Yes, yes, sir.
Okay, thank you.